This week we'll be discussing motor and sensory impairments that have communication disorders as a secondary condition to the motor and sensory impairments. Okay, so they can be comorbid conditions which occur with speech and or language deficits, or secondary, which the condition is secondary or part of another more significant disability. And this chapter breaks it down into motor system impairments, visual impairments, and sensory impairments. The motor system impairments involves problems with oral motor systems control as well as difficulty with limb control. This is a neuromotor dysfunction. And of the neuromotor dysfunctions, it classifies the two different types of dysfunctions, apraxia and dysarthria. Dysarthria affects speech motor control, which is voluntary and related reflexive functions. Your reflexes being swallowing and breathing types of motions, chewing, sucking, swallowing. Sorry, I was looking for my notes. And then it's a disorder of the central nervous system and affects the peripheral nervous system. The reflexes dysfunction, you will see drooling, swallowing difficulties, and in the voluntary dysfunction, they'll have difficulty imitating speech sounds and gestures. Often, children with this difficulties have cerebral palsy, which we classify as other health impairment under the IDEA guidelines. They can also have muscular hypofunctioning, which is weakness in the muscles, or muscular hyperfunctioning, which is excessive muscle contraction, or hypertension is how I think of it, that they aren't loose. Their muscles are extremely tight. Our student who has some disfluency type behaviors, I've mentioned her before, she's very determined. She's always working hard. She has borderline CP according to the doctors because she was past 3 when she was diagnosed, but she does have a lot of motor deficits related to hyperfunctioning, a lot of tightness in her muscles, and you can see the tightness whenever she's writing and she receives occupational therapy for those dysfunctions. The next motor system impairment is childhood apraxia of speech. And I've focused a lot of attention on this because you're throughout this term a lot at the beginning of the term when talking about articulation and phonological deficits. So when you're looking at childhood apraxia of speech, it involves the central motor planning difficulties affecting voluntary oral motor movements, but not affecting reflexive functions. So this won't affect any of the swallowing functions, only the voluntary movements. You can see this, that affects both the accuracy and sequencing of phoneme production. They have a limited phonemic inventory, difficulty producing smooth transitions from one articulator to another. So a front to back transition or a back to front transition is very difficult for them. When it talks about incidence, it has an estimated prevalence of about 1 to 10 children per 1,000, which is, to me, 1 to 10 is a wide range. And it may be the primary diagnosis for about 5% of children with speech sound disorders. However, if you keep reading onto the next page, 154, the next last paragraph in this section is talking about the assumption that children with CAS would have inconsistent patterns of speech sound substitutions compared with children with other forms of phonological delay. This was a small study, only 3 children. It showed that children with CAS produced more errors than children with phonological delay, but with similar consistency. So they had more phonological errors, but the errors were still phonological in nature, which suggests a dimensional difference rather than a categorical difference, and would actually put these children with childhood apraxia of speech into the severe speech sound disorders category, which is different than the motor speech impairment. So we've brought this up a lot in our discussions, and I know I've been kind of moving us towards that as we've been discussing these things. Unintelligibility does not equal apraxia. I think this term is very overused in our field sometimes. We need to be careful when we're making that diagnosis because they have to have these types of characteristics. They have difficulty performing intentional voluntary imitation of non-speech oral motor gestures. However, the research has been very clear that it's ineffective to do oral motor therapy in therapy or to practice oral motor skills because it does not improve speech sound intelligibility. And you can Google that on ASHA. It's very extensive. They have vowel errors, so their vowels are different than the consonants. In phonological processing, you typically don't see vowel errors. They have inconsistent errors. Sometimes the error might be an M, sometimes it might be a B, sometimes it might be a P. And sometimes it might be produced correctly, so the errors are not consistent. Whereas a phonological disorder, they're always doing T for K, they're always doing D for G, very consistently across words, phrases, sentences, and conversations. They have increased errors with longer speech output, but you could also argue that the increased errors with longer speech output could be a phonological process due to syllable reduction processing. When the longer the syllables get, the less the phonological memory, working memory that they have, so therefore they reduce the syllables. So does that mean that they're apraxic, or is it still that phonological language type of impairment? In addition, a big discussion around this is that they have reduced expressive versus receptive language skills, but generally you'll find that their language skills overall are more deficient. So it's a chicken or the egg. Of course, you would think if they would have expressive language deficits if their expression is so unintelligible. But you also can find receptive language deficits when it comes to their vocabulary and lexicon knowledge. And is that because the Matthew effect again? Because they're not reading as well. They're higher risk for literacy deficits. Therefore, they don't have those vocabulary skills. By adolescence, they can produce intelligible speech, but they may have persisting phonological sequencing and non-word repetition difficulties. And at the beginning of the discussion, it does talk about the dysarthria and apraxia children could qualify under other health impairment under IDEA. And I have known one student in my career that qualified as OHI with a childhood apraxia of speech diagnosis. However, that diagnosis was really not appropriate, and by the time he was in high school and had a more comprehensive evaluation, they found him to be more cognitively disabled with a developmental learning disability. So again, that CAS wasn't really the apraxia type characteristics of errors that he had were truly more related to his overall functioning ability and his overall language, which was very, very limited. All right, and then the last discussion, motor system impairment is complex communication needs. Of course, we always need to consider augmentative and alternative communication systems for children with severe motor speech difficulties, particularly these children with cerebral palsy. There is a difference between non-speaking versus nonverbal. Non-speaking implies insufficient natural speech capability to support functional communications. That would be your cerebral palsy child. Versus nonverbal implies a lack of words, so their lexical knowledge is lower. So you have seen that in studies that these students have receptive syntax abilities that are spared amongst children with severe speech and physical impairments. So a lot of times their cognition and their overall receptive language ability is intact, and it's not impaired even though their motor impairment is so severe that they cannot have functional speech or communication. But they can learn to use AAC to communicate sophisticated messages in spite of motor impairments. They are at a higher risk for language and literacy learning difficulties because of the influence of in concentration on speech sounds and the phonological awareness component. So if you're having difficulty producing the sounds, you might have difficulty understanding that sound symbol relationship and hearing the distinctive features of those sounds. They also have higher risk for additional sensory and cognitive linguistic system challenges in conjunction with their motor performance difficulties. But you have to remember there's no prerequisite for considering AAC because they might appear to not have the abilities, but you need to give them every opportunity. It's better to make the assumption that they can than the assumption that they can't when they actually can. If you've never seen the movie My Left Foot, it's a good movie to watch about a person with cerebral palsy who was so severely impaired in their motor speech capabilities, but was very functional and high performing in their cognitive abilities. And you want to give them access to written language, because access to written language will give them access to communication and other life skills across many, many settings. It is also interesting to note in the summary on page 156, when it's talking about childhood apraxia speech again, that autism spectrum ASD students, autism spectrum disorders, have a heightened risk of CAS. So sometimes when you see that in the student, it might be an underlying condition for a bigger disability than just childhood apraxia of speech. Now we're moving into auditory system impairment. And when it's discussing this, it talks about the different classifications of hearing impairment. There's deafness, which is complete or near complete loss of hearing, versus hard of hearing, hearing impaired at 80 decibels or lower. Some new technology is even saying 90 decibels. So their loss is at the 90 dB level, but they're still functional enough with their aids to be hard of hearing and not completely deaf. But it is absolutely critical that they get identified early, because they show that for students, or for children rather, that are identified through the early hearing detection, newborn hearing screening in the hospital, if they're not screened at birth, many children with abnormal hearing proceed into the 3rd year of life or beyond before a hearing problem is suspected. So it's absolutely critical we get them early, preferably when they're born, leaving the hospital. This is the early hearing detection and intervention policies. We do have a law in Mississippi that mandates that every child be screened for hearing prior to leaving the hospital. So both of my children have been screened, and they tell you on discharge, your child passed the hearing screening, or your child failed and needs to have further assessment. So it's really critical for them to get identified prior to 6 months of age. That's the magic number for them to be the most successful with interventions, and also the parent interaction, because earlier when I was talking about the different stages of development, parents interact differently with these children, knowing that they have the impairment, and it improves their long-term outcomes. We wouldn't want to hit that hard and get them before they're 6 months. So 1 to 3 infants per 1,000 are born deaf or hard of hearing, but it could be even higher because of high frequency and conductive losses if they were included. That's just talking about sensory neural hearing loss. But we have to be doing a good job as far as professionals about getting the word out there about hearing loss and appropriately identifying these children before that magic 6-month age, or if they miss that, just as early as possible. Okay. This is the classification of hearing losses. Congenital hearing loss is present at birth or shortly after, versus an acquired hearing loss that happens later in childhood, adolescence, or young adulthood. So there was an event that caused the child to lose hearing. If it's a prelingual hearing loss, that means they never developed language skills before losing hearing, versus a postlingual, the onset was after the first language is acquired. Hearing loss can be progressive, and then it becomes progressively worse over time, or it can be sudden with acute or rapid onset. It can also be fluctuating, which means it changes depending on the day, or it can be stable, which is more often a sensory neural hearing loss. I do have a auditory neuropathy student this year for the first time ever, my first hearing impaired student in 10 years, in fact, and it's such an interesting experience with that student this year and working with her. And you can tell the days, the auditory neuropathy is fluctuating, and so you can tell the days when she is hearing better than others, and she's more oral on those days. Brief overview of the parts of the ear. There's the outer ear with the pinna, external inner canal, and the tympanic membrane. The middle ear is made of the ossicles, those 3 bones, teeny tiny smallest bones in the body, malleus, incus, and stapes, and the eustachian tube. And the inner ear is the cochlea and vestibular system. There are different types of hearing loss. Conductive hearing loss occurs in the outer or middle ear, and of course this is usually a temporary loss. It's not permanent, versus a sensory neural hearing loss. It's a permanent hearing loss and socioimpairment of the cochlea or retricular neural pathways, which go beyond the cochlea into the 8th cranial nerve or the auditory nerve. For hearing, I skipped mixed hearing loss. And mixed hearing loss involves a combination of sensory neural hearing loss and conductive hearing loss. For hearing testing in the infant population, birth to 6 months, they use the auditory brainstem response to screen hearing. Now, this isn't 100% accurate, and a child can have a hearing loss diagnosed even after they've left the hospital and passed the hearing screening, but it's the best we can do whenever they are there, and I'm so glad that we have that in place as a mother and an SLP. Once they hit about 6 months of age, they can sit up sufficiently and orient clearly enough to do visual reinforcement audiometry, which is you condition the baby to turn to the direction of a sound source, reinforced by associated antics of a mechanized toy. From about 2 to 5 years of age, you can test them with conditioned play audiometry, which is you put the pegs in the holes when you hear the sound, or a ring on a stick. We'll use blocks in a bucket, put the block in the bucket. But when we do that, we usually have air conduction testing, which is the traditional hearing screening with an audiometer, screening at decibels, which is the sound level, and hertz, which is the frequency of the sound, the cycles. Then there's bone conduction testing, which are compared with air conduction results. I'm not an audiologist, so I'm not even going to try to explain this beyond what the book explains as far as measuring air conduction. And tympanometry usually falls in this. And it also states about how otoadmittance methods are considered objective because there's no behavioral response on the part of the child. So that can be used in children who are low functioning that you can't condition to hearing screening. And we recently had one that we couldn't condition to hearing screening, and he's a 5-year-old, which is highly concerning because even our preschoolers can be conditioned. But we tried the what's the name of it? We tried the pilot audiometer, and it's pictures of different words: sandbox, rainbow. They're all 2-syllable words with various different distinctive features of the consonants, and it starts at 50 decibels and comes progressively lower until you get to about the 20 dB range, and the child points to the picture when she says the word. Well, he didn't have the vocabulary knowledge to be able to point to the pictures, so he didn't know which one was a sandbox versus which one was a high chair. We tried the blocks, we tried the testing with the teacher and seeing who would interact with the teacher if the teacher helped him to do it. We tried to do observation of eye gaze to see if his eyes were moving towards the sounds whenever he heard the beep, and there was absolutely nothing. So therefore, he was referred for comprehensive audiologic evaluation because we can't determine, and we don't suspect that he has a severe hearing loss. There might be some hearing loss there, but any hearing loss that might be there probably is not the primary reason for his learning deficits. So it's very complex, but whenever you can't condition a child to hearing screening, it's highly, highly concerning, especially based on what this is saying as far as developmental levels. And then it does talk about auditory neuropathy again. That's the child that I have this year. It's impairment beyond the cochlea as the disrupted auditory nerve activity. And it's like Charlie Brown speech. That's what they hear. It's very muffled, and you can't distinguish the features. But the cochlea has normal functioning, so the breakdown occurs after the cochlea along the nerve pathway. I posted a link to a site where you can do hearing loss simulations, and it has a good hearing loss simulation for auditory neuropathy that I've played for my teachers, her hearing impaired teacher, my assistant principal, my principal, anybody involved with this child to say, okay, this is what it's like when she's hearing, so we cannot use traditional oral communication with her. I haven't had an opportunity to play it for the parents, but when I do, I will, because it'll help to inform them, because they choose to be completely oral with her and no supplemental communication. And I'll talk about that a little bit more when we get to the next slide. So you have the degrees of hearing loss: mild, moderate, severe, and profound on table 6.1. And the moderate loss is mostly what's going to be qualifying for speech. You might have some mild loss that qualifies in schools depending on the degree of the loss and the impact it has. But hearing screening in the schools, you have to pass at 25 decibels and not 20 or 15. So you could have a child that passes at 25 but doesn't pass at 20, but wouldn't be considered to be a hearing impaired child, just maybe a mild loss. It's not the school's job to identify every single deficit of every child. It's our job, as far as special education, it's our job to identify a deficit that qualifies them for special education, or that would impact them to the degree that they couldn't hear in the classroom and affect them academically. Then there's the configuration of hearing loss, and that's when you see across the frequencies on the audiometer what frequencies they hear. The hearing loss can be unilateral or bilateral, and a lot of times unilateral hearing loss they won't aid because it can supplement enough with the hearing ear, but sometimes they do. So it always makes it interesting when you're treating those students, because with the aid they're hearing things one way, and then with their normal hearing ear they're hearing it another way. So those students are very interesting to work with, and I've had one, maybe two unilaterals in my career so far. And then symmetrical versus asymmetrical loss, where the degree of loss might be more severe in one ear versus the other, or it could be equal across the ears. So language and hearing loss. The sensory neural hearing loss is permanent. It cannot be medically corrected. However, this is not applying to cochlear implants, because cochlear implants would be surgically implanted, but it doesn't correct the hearing. It affects the ability to hear sounds and distort sounds. Hearing loss does. A lot of the prevention things that we do are aimed to prevent to reduce loud noise hearing loss, so loud noise protection, particularly from iPod use, concerts. There was a great NPR article featuring Nancy Alarcon, our MISHA pre-conference speaker, who was at the University of Washington in Seattle, and they were talking about how the Seahawks were breaking the record for the loudest stadiums, and they were in a contest between them and the Kansas City Chiefs, and they were reaching decibel levels of 140 dB. So they were passing out earbuds, or earplugs rather, to put in their ears during the times where the fans were trying to raise those loudness levels to break the Guinness World Record. So there's a lot that ASHA does with this. Listen to Your Buds campaign. That's the primary prevention that we're doing right now. There are the terms hard of hearing versus deafness. Hard of hearing are those, again, 90 dB or below loss, versus if the loss is at 9 decibels or greater, they're considered deaf. However, this is considered outdated terminology because modern amplification and surgical techniques have allowed children to be moved from one classification to another. So a child who would have traditionally been seen as deaf may now be considered hard of hearing because of a cochlear implant. Now, the language and literacy outcomes depend on multiple factors of with the hearing loss, including type of loss, degree and configuration, knowledge of speech and language prior to the loss, so was it a prelingual or postlingual loss, the quality of the amplification system, when it was fitted, how often it was worn, and familial and cultural and other child-specific variables. So my hearing impaired student, she's a kindergartner, they've had her aided, but they don't aid her consistently. We just got consistent aids really right before Christmas for the school year. They choose to communicate orally with her because that's what they would like. They have not learned any sign language. However, she cannot perceive speech anywhere except when you're facing her. But the parents don't make accommodations to this. Her vocabulary is very limited and deficient because she's had no other communication system in place besides oral, and she's hearing impaired. So we're having to work a lot with that family and trying to build their knowledge and improve what's happening in the home as far as consistency with maybe a little bit more sign language, consistent face-to-face visual input for her. And the speech banana, you can definitely tell the sounds that she can and can't hear. We've worked for a while on the K and the G sounds, which would imply a lower frequency loss, which is, I think on her audio team, I'd have to look back. But she could not distinguish or hear those sounds. So when we were going through association method with her, we've started that before Christmas, and it seems to be going well. So we have thus leading into the communication choices. Total communication is how we're training the student. We do sign, we're using literacy, letter, sound, correspondence, and vocabulary through association method and other just general academic methods. Anything we can to help her communicate, because her language is so limited at this point. She doesn't have a functional communication system in place at 5 years old. There is auditory visual with speech reading. There is auditory verbal only, and that would be the association method. And then there's sign language only, which is very traditional in the deaf community. And the deaf community, deafness is referred to a difference, not an impairment within their community. And they value the ASL language as much as anybody who speaks a language does, because it is another language, just like Spanish or French or English. And the children who are born to ASL parents do very well because they have a rich integrated vocabulary system, because the parents are fluent in ASL and they're constantly integrating that throughout the child's life. However, the deaf and children born to hearing parents who aren't fluent in ASL, they have more difficulties and have more vocabulary deficits. But a lot of these children are candidates for cochlear implants, which transmit acoustic info to the auditory nerve directly, bypassing the cochlea, or bypassing, the impaired nerve endings. And initially, the cochlear implants weren't perceived very well in the deaf community because they were afraid they were going to lose their identity, their hearing impaired identity, their culture. But it is opening up more now, more accepting in recent years, because they can see the benefits of it and how it makes them more functional overall across different settings in society, not just within their own small community. Right? The research on language and conductive hearing loss, language risk with that, of course, the sensory neural hearing loss and language risk are very severe. With conductive hearing loss, it is a temporary hearing loss. It can be treated with antibiotics or pressure equalization tubes, PE tubes for short. My own child, Kennedy, had PE tubes when she was 11 months old because we had those consistent middle ear infections 3 months in a row, never cleared up after antibiotics, just never cleared up after any intervention, after the wait and see. I went to the pediatrician and said, it's time for tubes, because I believed as an SLP that I didn't want her to lose any hearing at that critical stage of language development. That was my opinion. It's not my research opinion. That's just my personal, from my work setting and experience opinion, as well as a parent. And so you have the serous otitis media, and that usually comes with allergies and treated with antibiotics. But because overprescription with antibiotics has happened, they're treating less and less with antibiotics for that. So in general, the child has the ear infection is diagnosed, and it's a wait and see. We're not going to medicate. We're not going to do PE tubes without meeting the certain criteria. So that is very difficult for the children and their potential language miss from that, the parents, because a child who's walking around with an ear infection all the time, it's not a happy camper. But that is the predominant thought right now because of our prescription of antibiotics and the parents not finishing the antibiotics whenever they're given. It's a very critical note about prescriptions. So those are your options, and evaluating the results, it's unclear if the timing of the tubes affects language development, whether they wait and see or whether they go ahead and intervene with tubes. Some studies have found small effects of middle ear effusion on depressed language development scores, such as vocabulary, where other studies have identified no effects. So the research is just not out there right now to indicate one way or the other whether or not tube intervention helps language development. This other study, when it was followed them from ages 3, 4, and 6 to age 9, there were no statistically significant differences. But when I'm reading that as the person who personally experienced it with the child who got the tubes at 1 year old, if she hadn't got the tubes at 1 year old, this age 3, they've already developed a lot of language by then and a lot of vocabulary knowledge. So it might not be that affecting, but what about the infants, the very, very young children, when they're growing words daily, and there's just tremendous language growth between 12 months and 18 months, or 12 months and 24 months. So I would like to have seen that explored a little bit further before making the determination that there's no statistically significant differences. All right, and then auditory processing disorder, the last in the auditory sensory deficits. These students have normal hearing, but deficits in central processing of detailed acoustic information. And we just had music, the researcher referenced throughout this section at MISHA conference. He's a very big researcher in auditory processing disorders, lots of information, and it has a lot of different descriptors here, but they basically summarized it in these 3 domains that are assessed: temporal aspects of hearing, which is pattern recognition; monaural discrimination, which is the ability to perceive words when the signal is degraded or presented with competing noise in the same ear. So you'll hear some static, and then you'll hear a phoneme, and you have to repeat whatever the phoneme was through the static. And then binaural acoustic information processing, or dichotic listening. They'll play the number 24 in your right ear, the number 16 in your left ear, and you've got to repeat the 2 numbers that were set. You can't just say 1. The temporal aspect was the ability to sequence auditory information when presented rapidly. So those are the 3 domains that are assessed. We have a screener that we do for auditory processing disorders that was it's developed by audiologists, and it says this is only a screener, and it gives you criteria for the areas that they fail when to refer to an audiologist for potential assessment of APD. But the problem with that is that oftentimes these students are showing the inattentive behaviors and possibly some linguistic deficits. So it's a chicken or egg. Again, which one was first? What causes the problems? Oftentimes we'll wait and see if they're medicated for ADHD possibly. Is there a change in them throughout that year after that medication has taken place? Are they more functional on this particular screener? So APD is another one of those disorders that there's too many circular causal patterns for it. It's influenced by their cognitive ability, the language ability, the attention and executive functions even. So it's very difficult to say sometimes whether the child's problems are truly auditory processing or if they might be more behavior related or more linguistically related, and it's a team approach. But APD has to come from an audiologist. No one else but an audiologist can diagnose auditory processing disorders. Visual system impairment. This is blindness or low vision, challenges with acquiring vocabulary and concepts of language, and social interaction awareness due to their deficits with the vision. Because even though they can hear adequately, you're going to miss lots of things by not being able to see and have that visual input. So a visual impairment can't be corrected to typical or visual field is limited. So typical would be considered 20/70 is low vision. So at 20 feet away, you can see what someone would see at 70 feet away. And so you have, that E chart. The top E is usually a 20/70 type E. Legal blindness was considered 2200 vision, and then blindness is 2400. The incidence of deafblindness, I'm sorry, not deafblindness. The incidence of blindness are under 1%. So it's a very low incidence condition. And it doesn't talk about the incidence for visual impairment. But it's low incidence. I've had very few students that were blind or low vision that I've worked with. It can be caused by anoxia, hydrocephalus, congenital cytomegalovirus, lots of different things that can contribute to blindness or low vision. There are also other eye conditions that can be considered a visual impairment. Amblyomyopia. Amblyopia. Sorry, it's late. Amblyopia is a regressive developmental condition that occurs when an eye-brain connection is not working. And then strabismus affects the ability to control eye movement for focusing and binocular vision. So those are other forms of visual impairment. Now, the language risk for visual impairment, they have lexical learning difficulties due to difficulty associating words with things or pictures. Pronoun references give them a hard time because you don't know who he is, because he can be anybody that's in the room. That could be a male. They have difficulties with social pragmatics because you're not going to see any visual cues, any eye gaze indications, of course, because you can't see. But the parents can help them a lot because they have, with distance referencing in the illocutionary phase, infants using finger pointing to perform speech acts that comment on or request toys, other acts, or food during the illocutionary stage of development. Even the visually impaired children can do this, even though they're not necessarily pointing to a specific object. They're still doing that interaction. So again, if they're identified early, the parents can change how they're interacting with them and make them more successful in the long term. Other problems you might see, they could have underextension, which is unlike overextension where you say everything with 4 legs is a dog. But underextension would be not being able to associate features to other things through their features, such as color in the apple example that the book uses. But the sight influences ability to acquire language concepts beyond nouns and communication functions beyond commenting or requesting. So there's the pronoun usage is a good example. And other forms of deixis, here, there, this, that. It's references to persons, place, or time that vary depending on one's communicative perspective. So visually impaired students will have difficulty with this. But the parents can give the heightened experience for the babies and make them more successful when they do that. Also, Braille for literacy use can heighten their language knowledge and experience. And then deaf blindness, it's very rare, very low incidence. It's 1 in 10,000 children is what the incidence is here. And it can encompasses hearing, visual perception, and communication, but it doesn't have to be complete loss of hearing or complete loss of vision. But when they combine them together, it's so significant they meet this classification of deaf blindness. So hopefully you might be hearing impaired, but maybe you're only hearing impaired at 60 dBs and you're blind. So you're losing your visual cues and your visual input, but you can be aided to a 40 decibel level and get some auditory input that way. The causes of deaf blindness, it can be prenatal maternal infection or disease such as herpes or syphilis, maternal rubella, substance abuse, or from postnatal disease like it's meningitis, encephalitis, or trauma. There's also the Usher syndrome, which is a genetic condition transmitted by autosomal recessive gene. And this is a primary cause of deaf blindness in children. I'm just remembering, backing up just a second to strabismus. I have a student right now with the syndrome, and he has strabismus. So, and this is the first time I've worked with a student like this. He cannot move his eyes at all. There's paralysis. He can't focus. He has to have drops in his eyes constantly. So anything that has multiple pictures, you have to cover any of the other pictures up because he has to move his head to look at each different picture. I believe it's strabismus. That's at least what I'm thinking strabismus would look like, and that he visually cannot track He has to move his head one way to the other, so no side-to-side eye movement. So I wanted to mention that you might come across these students, and they have multiple needs in addition to communication that need to be addressed through a comprehensive multidisciplinary intervention team. Okay, and then back to deaf blindness, Usher syndrome, and if you give them access to literacy or augmentative communication options, it greatly increases their functional abilities and performance across settings. Finally, other sensory system problems. You have difficulty processing near sensation. Proprioceptive feedback is the body's position in space. Somatosensory or textual feedback from touching objects with different textures, including food in the mouth, such as pica. We had a ASD child one time that had some pretty severe pica, and the things he would eat were just unbelievable. Kinesthetic feedback regarding the weight and positioning of the body and motion. Then you have hyperacusis, adverse reaction to sound. So all of these sensory deficits would lead to a diagnosis potentially of sensory integration disorder. So they have it's a neurodevelopmental disorder of relating and communicating is the other term used for in the book. They have hyperarousal and hypoarousal to normal sensory stimuli that can be observed among infants and young children, but may be overlooked when other issues of self-regulation and social interaction seem primary. So you might notice it, but there are other deficits might be interfering with the diagnosis for the sensory integration. I like the example. So you like the babies that you pick up, and instead of just cuddling into you and embracing you, they might pick up and they just arch their back and lean away. They're just so overstimulated. You can definitely tell these children apart from early on. So oftentimes these characteristics are in line with some of the descriptors for pervasive developmental disorder, which affects social relationships, language, cognitive functioning, and sensory motor processing. Now, this is referencing the DSM-4, TR, and in the new Diagnostics and Statistics Manual 5 that just was released 2013, PDD is no longer a term used for ASD students. It's just generally ASD. So these terminologies would fall under students with potential autism spectrum disorders. So this can, if they have sensory processing difficulties, it leads to problems involving social, emotional eye gaze, shared attention, and joint action routines. So that's how it influences their communication needs. And they might end up later on with a pragmatic language impairment. But typically, if you have a student with these sensory type issues, it would warrant an evaluation from an occupational therapist, because they're the ones whose realm is sensory and sensory integration. And we can always get some good strategies, such as some weighted vests to help them feel more weighted in their space, or sometimes they'll suggest them sitting on an exercise ball so they can't move around and wiggle out of the chair. They have to balance themselves, and it helps regulate their sensory input that they like to have by moving around. So very interesting. You're not going to get an IDEA ruling for sensory integration disorder, or it would fall under another classification for SPED services, such as maybe a developmental disability if they had the problems in the social pragmatic skills, that weakness, and in addition to the language deficits.